Hey guys, thanks so much for joining us today. My name is Emma and I'm the founder of the Pelvic Hub, and we are here today with Nicole Cozean from Pelvic Sanity. Nicole is a physiotherapist in the USA. She's based in Orange County, California, and she has a clinic called Pelvic Sanity. She is the author of the Interstitial Cystitis Solution, and she is on the Interstitial Cystitis Association Board of Directors in the US. So thank you so much for joining us today, Nicole.
Yeah, thanks, Em. I'm so happy to be here.
This is really exciting. We're going to be talking about the important orthopedic pelvic floor connection. So I think a great way to start will be just to ask you, what is the pelvic floor?
Perfect. Okay, so the pelvic floor is a general term that essentially encompasses anything that you see here in red. So it's a series of muscles, connective tissue, fascia, ligaments, all that attach to the pelvic girdle. We have them attaching to the pubic bone all the way back to the tailbone, and each sit bone to sit bone. If you take a look into the pelvis, as if you're looking down into someone's pelvis, again, anything that you see red here is also muscles. An interesting thing to note is that every single one of your pelvic floor muscles in some way attaches to the tailbone. So we'll talk a little bit about that more when we talk about the ortho-pelvic connection. But essentially, that is what the pelvic floor is, and we'll talk a little bit now about what it does.
Yeah, so there's a lot of muscle there we don't realize. So what does all of that do for us?
So the pelvic floor has essentially four major functions. So the first function is that it has a stability function. So because of all of its attachments to the different parts of the pelvic girdle and the tailbone, it essentially stabilizes your hip and your low back. Dysfunction, though, happens when the pelvic floor actually becomes the primary stabilizer and isn't the secondary stabilizer like it should. So in essence, it should just be helping the abdominals and the back muscles, but sometimes if those muscles are dysfunctional, the pelvic floor has to grip and come to the rescue, and there can be some dysfunction associated with that function. So that's stability. So the second function that we have is the supportive function. So what's not pictured here are the organs. So we have the bladder for both genders and the rectum for both genders, and then we have the vaginal canal and the uterus, and they literally all start in a line here. And the pelvic floor is not just a clever name, it is literally the floor of the pelvis, and without it, or if it becomes dysfunctional, those organs can essentially start to sink and move and drop into places where they're not supposed to be. That's called pelvic organ prolapse. So the third function of the pelvic floor is also a sexual function. So for both genders, the pelvic floor is responsible for sexual pleasure and also for helping with sexual arousal. So in cases where that starts to become dysfunctional, you either have sexual pain for either gender, that's either painful ejaculation or painful erection, or for females, then it would be painful insertion. And then the fourth function is a sphincteric function. So this is what most people think about when they think about the pelvic floor. And that is the ability of those pelvic floor muscles to squeeze off those openings so that anything that we don't want coming out from the bladder or the rectum, it just stays in its little organ instead of coming out when we don't want it to. So what happens with it being dysfunctional is that it's either gripping too tight and it doesn't allow the full release of either the bladder or the bowel, or it is not functioning optimally and actually squeezing off those openings well, and then we actually have involuntary loss of either bowel or bladder. So that's called incontinence. So those are the four major functions of the pelvic floor.
So what would you say to people that say they don't see people with pelvic floor issues?
This is a great question. So we typically think of these types of pelvic floor dysfunctions historically with older women.
Yeah.
I think that's a pretty common, misconception actually. But I'm going to kind of share with you a few stats that'll sort of blow your mind just to talk about the prevalence, especially in younger men and women with pelvic floor dysfunction. So 55% of women under the age of 65 actually have some form of urinary incontinence.
Yeah.
So that's a lot. And it's even up to 30%, wait for it, of female collegiate athletes. So the people that are supposed to be in the prime of their athlete or athletic capability actually have signs of incontinence. Postnatal symptoms are another area where we find a lot of pelvic floor dysfunction that is accepted as common, but we want people to realize that that's not normal, and practitioners need to realize that it's not normal either. So 25% of people that have had a baby recently within the last 2 months have painful intercourse. Again, a common but not normal symptom and a sign of pelvic floor dysfunction. 77% of people that have had a baby also have low back pain. And then as a separate aside, in the general population, there was a study that was done that looked at the prevalence of low back pain and pelvic floor dysfunction and found that 95% of people that had low back pain also had pelvic floor dysfunction to accompany that back pain.
That's a lot.
That's a lot. So if anybody that you're seeing, both in an exercise capacity or in your practice as a GP or any other office, has low back pain, it's pretty darn likely that they also have a component of pelvic floor dysfunction. One of the other big things that we don't typically think of as a pelvic floor problem, but it actually is a huge component, is diastasis recti. So, or diastasis, you can say it either way. So that's where the rectus abdominis muscles actually split. It happens to 100% of people in pregnancy, so you can't really avoid it during pregnancy, but 40% of people postpartum, actually that split stays. And what it means though is that the very intricate relationship between the abdominal muscles and the abdominal cavity and the pelvic cavity is really disrupted with that. And so you really can't have a diastasis without having some form of pelvic floor dysfunction associated with it. So there's a very big pressure system. If you think of this as like a canister, the abdominals form the front part of the canister, the back muscles form the back, the diaphragm actually forms the top of the canister, and the pelvic floor muscles are the bottom. And all of those things have to work together in order for each one of them to function optimally. So that's another very common postnatal symptom that also involves the pelvic floor.
So you mentioned postnatal, and we obviously think about the pelvic floor when women have a vaginal delivery, but what about C-sections?
Yeah, this is another area where a lot of people think that, oh, because I had a C-section and didn't deliver vaginally, that you wouldn't have any sort of pelvic floor dysfunction. But all of the changes that happen during pregnancy also affect the pelvic floor. And remember that the C-section itself actually cuts through a bunch of the abdominal muscles and disrupts that whole relationship that we just talked about with that abdominal pelvic canister. So in fact, all the statistics that we just talked about for postnatal symptoms are still present regardless of the type of delivery that you've had.
Oh, interesting.
Yeah.
Cool. So those are, I guess, more obvious pelvic floor related symptoms. Can you tell us a little bit more about the less obvious, maybe more orthopedic conditions where the pelvic floor could potentially just have a little sneaky involvement and go under the radar?
Yeah, so this is also a big area where I feel like as practitioners or exercise specialists, we can really use our anatomy knowledge to sort of bridge the gap between something that we think of as primarily an orthopedic condition, but actually can be having a pelvic floor involvement. So let's take, for example, hip pain. So hip pain is, so this is obviously where the acetabulum is and where the hip joint itself is. But if you also think of the attachments of all of the muscles around the hip joint itself, we have a bunch of muscles that attach to the pubic rami. We also have a lot of muscles that attach to the ischial tuberosity, all that are part of the hip musculature. The other big one that most people don't think of is a muscle called the obturator internus. It's kind of like a cousin to the piriformis muscle. It has some of the same actions, but in fact, it is in this whole big internal component of the pelvic floor. And so we can really only access it internally. You can access it a little bit externally, but the biggest muscle belly part is all internal. And so it attaches out and does the same action that the piriformis does, but its trigger points in the muscle belly or its dysfunction can actually mimic things like anterior hip pain, labral tears, hip flexor involvement, and so it's a really big area to potentially look for potential pelvic floor involvement if the person that you are working with has also like complaints of hip pain, especially with movement. Another big kind of sneaky little thing to work on is the tailbone. So remember that we said before that every single one of your pelvic floor muscles actually attaches to this tailbone. And a lot of your patients might not, or the people that you're working with, might not actually associate tailbone pain with any sort of pelvic floor pain. They might actually describe it more as really low back pain or glute pain. But in fact, if you actually ask them or do an assessment with a pelvic physio, we actually find that the tailbone attachment itself to some of those pelvic floor muscles can actually be the primary pain generator in some of those people. So that's another muscle that can be a very big factor in the orthopedic component of the pelvic girdle.
Thank you. So you developed the Cozean Pelvic Floor Screening Protocol so that we could, I guess, pick up these pelvic floor issues that patients and practitioners don't necessarily think, oh, that's pelvic floor dysfunction. So would you be able to tell us a little bit more about that?
Yeah, so this was actually born out of necessity at my own practice because I was all excited talking about to all my colleagues about, oh, you guys need to screen for pelvic floor dysfunction. Please talk to your patients about it. And they were like, absolutely not, Nicole. I am not going to start asking my patient all these crazy questions about urinary dysfunction, bowel dysfunction, sexual functioning when the person isn't really expecting it. And so what I ended up doing was I created this easy to administer 10 question screening protocol that sort of does all that dirty work for you. And so really as a practitioner, and no matter what field you're in, whether you're a GP, whether you're a urologist, whether you're an OBGYN, or whether you're a Pilates instructor or an exercise specialist in some way working with somebody, you can administer this the same way. It's just a 10 question questionnaire that asks about the functions that we were talking about of the pelvic floor. And the way that we developed this tool is that I took a subset of patients from my clinic and that already had confirmed pelvic floor dysfunction that had an orthopedic component to it. And we did some nerdy statistics called a regression analysis.
Love it.
And we looked at the most common correlative questions that all of these people had in common regarding on their intake form. And so we found that if the person answers yes to 3 or more of these 10 questions, then it is 91% likely that they have a pelvic floor dysfunction component to whatever it is that they are having a challenge with.
Yeah, that's a lot.
Yeah.
Just 3 out of the 10 questions.
Yep, 3 out of the 10. So it's very highly sensitive, meaning it captures a ton of people that wouldn't otherwise know that they had pelvic floor dysfunction as a potential component. And it would be best then to refer after that to a pelvic physio who is an expert in the function of these pelvic floor muscles that we just talked about. So, yeah.
Yeah, wonderful. So you mentioned that it's great for everyone to be able to use to screen their patients. Obviously 10 questions does not take much time, and you could use it just as an intake form, conversation starter, to then refer to the appropriate pelvic physio. How do you then work with, what happens, for example, if a exercise physiologist or a Pilates instructor or anyone does this wonderful screening protocol, highlights issues, refers to you, then what?
Then we have a wonderful open collaboration with both people's expertise, right? So if you're going to refer to a pelvic physio, one of the things that I've heard a little bit of pause for is that, oh, well, then that means that I can't continue to work with them or something like that. But at the end of the day, what you're going to end up doing is you're going to end up using both your expertise and the thing that you saw with their progress, and then combining that with like a pelvic physio's expertise on the exact function or dysfunction in this case of what might be creating that issue, and then we're going to work together and use our expertise so that we can better the patient. So it just really means that you're going to do the referral concurrently with whatever they're doing. And if you're a GP or a urologist or any other type of physician, then you are going to use this tool to screen just like you would screen any other system of the body. I just feel like pelvic floor health in general is sort of a castaway and isn't usually a focus, and I believe that there's a lot of reasons why we should pay more attention to the pelvic health of our people. So, and as a general practitioner, you can be at least the conversation starter.
Yeah. That
there is help to get some more expertise into that area and address any issues that might come up.
Yeah, and the more we all talk about it, the less shame and embarrassment is around it, and the better outcomes we'll get for all of these people. So do you have any other comments or recommendations you'd like to share with us today? Yeah,
I just feel like this is an area that I really feel like we can use both of our expertise. So pelvic physios are experts in the neuromuscular and musculoskeletal involvement of the pelvic floor and how that functions in a larger biomechanical process. And so using the protocol can help to educate both practitioners and patients to see if there's any sort of reason why there has been a lack of progress, or if there's a whole nother avenue that patient might want to go down for better quality of life. So I think we can use that as a tool just to better pelvic health across the board and have an open, collaborative, multidisciplinary field for pelvic health.
Yeah, that's so awesome. Thank you so much for chatting with us today and for sharing all of your knowledge and coming up with that wonderful Cozean Screening Protocol. I'm sure we will all be really excited to use it in our practice. And if you want any more information or resources, Nicole has a lot of information on her clinic site, pelvicsanity.com. If you'd like to come on and look at any of the products or resources we have at the Pelvic Hub, you can come and check us out at thepelvichub.com. But yeah, thank you so much, Nicole, and thanks so much everybody for tuning in.